Okay, so this chapter was paniculitis, and so really the kind of branch point or breakdown point is you look at it and you say, okay, is it primarily septal or is it primarily lobular? And understanding that there's going to be spillover between the two, so anything that's primarily septal is generally going to have some spillover into the lobules, and even the things that are predominantly lobular are going to have some spillover into the septum. So it's really never that clear cut. But if you use that branch point, it will at least help you. So let's go to scan on this one because it's a big piece of tissue. So somebody did a either really, really large punch or likely a wedge excision here. And so focusing at first on the dermis, sometimes looking at the dermis when you're looking at the paniculitis will give you some clues. So this one, if you just omitted the subq and looked at what you have in the dermis, there are some clues, right? So what catches my eye at scan is that you really have this superficial and deep perivascular, really pretty dense, looks like predominantly lymphocytic infiltrate, right? And over here especially you can appreciate that there's some increased spacing between the collagen as you get down the deeper kind of reticular dermis there, so you could imagine that perhaps there's some mucin scattered in there. So you have some clues at scan, and then as you go down deeper, you know, the lymphocytic infiltrate continues, and you can see what I was talking about here where it's really not clear cut. Like you have, let me see if I can get the arrow to work. So here's some kind of spillover of the inflammation into the septum, but if you look, you know, it's predominantly going to be a lobular process here. This lobule's affected, this lobule's affected. So this is, I think, you know, Dr. Alston's sort of chicken soup, I think he calls it. And so another clue at scan is you have this kind of hyalinization. See all the kind of the pink sort of hyalinized change you see there, hyalinized change you see there. Another clue in this entity, which it's not really great in this example, is that you can get these lymphoid follicles. So this is lupus, right? So you could see that this person has, you know, superficial and deep lymphocytic infiltrate at scan, and you know, lupus is in the differential for that. Ideally, you'd want to see some interface change even at higher power at the DEJ, unless it was tumor lupus. But we have a lobular paniculitis, we have, you know, lymphohistiocytic, we have hyalinization, and those are all clues, but the fact that you have lupus overlying it is really helpful. A lot of times in lupus, if you go on higher power, you will have plasma cells. They're not required, but you do tend to get a plasma cell infiltrate. So here you can really see the hyalinization a lot better. So one of the main things in the differential when you think it's lupus paniculitis is to consider, could it be subcutaneous paniculitis like T-cell lymphoma, because they can be hard to distinguish, and so, you know, you want to know history, and you want to, you know, this piece is folded over. Let's go out here.
I think their bulb is not turned all the way. There you go. Bless you.
So in this, to me, I don't see any, you know, atypical lymphocytes catching my eye. I don't really, you know, in subcutaneous paniculitis like T-cell lymphoma, the big atypical lymphocytes sort of rim the fat cells, but the pictures in the books are always nice and clear cut, but probably in reality there's a little more of a blurred line in terms of distinction. Okay, let's go to the next one. Alright, so this one, once you've seen it, then you'll pretty much always be able to recognize it, especially when you get one that has characteristic change like this. So if you ignored the, you know, superficial part and you're just looking at the dermis, you might be a little bit confused because it almost looks kind of layered cake, I think. But if you look here, you know, here's the main process down here, right? Here's the primary pathology, and you have this kind of saponification and ghost cell change of the fat cells, which nothing else really looks like this. If you have, you know, early pancreatic paniculitis, it can be a little bit more diagnostically challenging, but this case has more of the, you know, classic features. So sometimes you can get calcium deposition too, and just necrosis. So here, these cells are all helpful here, these guys. But probably the best cut is going to be here. So just burn that in your brain for pancreatic paniculitis. Okay. Alright, so I'm not sure why such a large biopsy is taken for this entity. But at scan you can see that there's kind of a granulomatous infiltrate surrounding the fat. And I think a clue here is that this doesn't look like adult fat, it looks like baby fat because the lipocytes are really tiny, which is a helpful clue. So you got baby fat, small little lipocytes, and usually the collagen in baby skin is going to be much more like brightly eosinophilic too, which can be helpful. And then, surrounding the baby fat, you have this really prominent granulomatous infiltrate. And then you have this kind of crystalline change within the fat. There's some better examples of it. And then in the giant cells too, you can see kind of this feathery crystal-like change. Higher power. So see in this giant cell you have that kind of feathery change in the cytoplasm. You can see it in this giant cell too, and then you can see similar changes within the lipocytes themselves. So you'd want history, but this is subcutaneous fat necrosis of the newborn, usually in full term, healthy newborns exposed to some sort of temperature extreme, rapid, usually related to, I think, like the rapid rewarming. And then in your differential diagnosis, you could consider Sclerosis neonatorum, which has the same kind of feathery change, but Sclerosis neonatorum is going to be less inflammatory, and the clinical scenario is going to be different because it's generally going to be a premature baby that has sort of that woody, indurated, firm skin. Things that can also mimic this in the differential would be post-steroid paniculitis is a big one, and then you can consider, cold-induced paniculitis too. I believe that post-steroid paniculitis can pretty much look identical on path to subcutaneous fat necrosis in a newborn. And that's like with the oral administration of steroids. Okay. So this one at scan, it seems like it's pretty well encompassed. You have this, not a true capsule, but you have encasement around the primary area of pathology. You can see it here. It's really pretty well circumscribed. There's a fibrous capsule, if you will. And then when you go in, here's normal, kind of healthy fat over here. This fat does not look healthy, right? There's basically degenerative change, and there's a whole lot of inflammation, kind of mixed infiltrative inflammation. Right, so that, I don't see a nucleus in that. I don't see. So these are kind of degenerating, and there's a ton of inflammation. So this is basically encapsulated fat necrosis. A lot of times you'll see it like on the breast of women after trauma, and a firm nodule gets biopsied. It's benign. So I think it has several names, like mobile encapsulated fat necrosis or nodular encapsulated fat necrosis. So this one I think is a little bit more challenging. So looking at it at scan, you do have some dermal infiltrate, like we talked about. You want to look at that and see if it's helpful. This one, in contrast to that first one we saw, right? The first one was really very classic for lupus with that tight kind of perivascular lymphocytic inflammation. This one, at scan, it's not quite as dense. It's probably more, there's some histiocytes probably mixed in there. It's not really a classic scan diagnosis for lupus. And then, to me, there's some thickening around these blood vessels. Like those blood vessel walls are really pretty thick through here. Let's go back to scan. So, your branch point, okay, is this septal primarily? Is this lobular primarily? So this one is primarily lobular, right? This one is pretty clean cut in terms of where the inflammation is, which is helpful. And then, looking at scan, okay, we don't have the overlying changes of lupus. We don't have the hyalinization. We have a lobular paniculitis, and then here we have a clue. So does this vessel look healthy? No, right? So there's clearly, inflammation and change that's occurred to this sort of medium-sized vessel down in the subcutis. So that's a really helpful clue for thinking about erythema induratum. So it used to be, that they split out erythema induratum and nodular vasculitis, not to be confused with fasciitis, which I found confusing in the beginning of residency. But nodular vasculitis and erythema induratum, they used to split them out where basically if you could find mycobacteria, then you would call it erythema induratum, and if you couldn't, then you call it nodular vasculitis. But the current version of Whedon basically says that they're now lumping them back into one entity. And so, the erythema induratum was thought to be sort of a tuberculid. Classically, these are going to be tender nodules on the calves, but sometimes you can see them on the shin. I will say that one thing to include in the differential is that polyarteritis nodosa can involve the medium vessel with some vasculitic change, and then a lot of times in PAN you will just get sort of overflow inflammation into the surrounding dermis, subcutis, whatever's around it. So it definitely should remain in your differential diagnosis. This one was labeled as erythema induratum, so I'm guessing the person probably had positive PCR.
I think I'm allergic to the carpet.
You can open the door if you want. If that'll be helpful.
Yeah, I was just reassuring the people next to me that I'm not sneezing all over them. Germs and whatnot.
Lucky Shane's over on the other side of the room.
Okay, so in contrast, when you look at this one, right, so do you see a ton of inflammation in the lobule? No. Most of the inflammation is kind of here at the dermal subcu junction, and then in these sort of fragments of septae. Again, here you can see it more kind of in the fibrous septa. You have some inflammation, and then along the DEJ, nothing going on in the dermis. So, when you see something that's primarily septal, your prototype is going to be EN, right? There are other things that can do it, but that's really the classic one. And EN, the infiltrate, is going to vary depending on how acute it is. So, in acute EN, you're going to see more neutrophils, and then over time it's going to change to be more lymphohistiocytic. So when you have a neutrophilic variant, you want to make sure you rule out infection. If you biopsy early EN. So this one to me looks like it has a mixture. I see newts in there, I see lymphs, I see histiocytes. So kind of mixed inflammation. Especially at the dermal subcutaneous junction here. And then if we go down here. So there's some granulomatous infiltrate as well. There's this is a foreign body type giant cell, and here's another one. So in erythema nodosum, which is what this is, if you see kind of little clefts with the foreign body giant cells, little granulomas radiating around them within the septum, those are called Michener's radial corpuscles, and they're helpful, or microgranulomas, and they're helpful clue to the diagnosis. These aren't really radiating around the cleft, but the fact that you have the little granulomatous component, I think, is helpful. So, EN, in contrast to erythema induratum, classically, that will be more on the shins, and there are a whole slew of causes, as you know. A ton of drugs can do it, especially oral contraceptives. A lot of different infections can do it. You can see it in the setting of loxins with sarcoids. So there's a whole list of things that are good to know. Okay, so let me put it on scan because this is a big piece of tissue. So somebody took a large chunk of tissue, right? So they wanted to make sure that they got subcutis, and there's a lot going on up top. You have some, acanthosis, some hyperkeratosis, some serum crusting. There's a whole lot of inflammation in the dermis. Kind of almost dense and diffuse on this end. And you have inflammation extending all the way down, into the septa. And as you're looking around, your eye is sort of drawn to these areas, right? The darker staining areas. Let's look around a little bit more. I think this is probably the best area to go in and look at. So the dark sort of basophilic staining is calcium, right? This shows up better. These are kind of like big chunks of calcium, little chunks of calcium. So when there's a question of calciphylaxis, you really want to find small vessels that are involved and look for those. Like, here you've got, calcium deposition. So you can get, I think it's called, path people can help me, I think it's called Monkeberg's medial. When you get with time, you get calcification in the walls of arteries. As part of coronary or just artery disease, akin to coronary artery disease. So you really want to find it in some of the smaller vessels. But this is basically an example of calciphylaxis. You've got calcium deposition all in the walls of small vessels. None of these are medium caliber vessels. And you have, go back to scan. A lot of times with this, you'll see areas of necrosis. So to me, this fat looks like it's dying there, and up top as well. And then to me, this looks like an area of necrosis, but it's hard to know when timeline-wise they biopsy this. But we get this request a lot because it's on the a lot of times in the hospital you get somebody that has retiform purpura, and they have a history of renal disease and a high calcium phos product, and they want to know, is it calciphylaxis? It can be hard to make a diagnosis based on a punch biopsy, because as you can see here, if you've just gotten a little 4mm punch, you might have gotten lucky and gotten it, but you also might have missed it. So this one clearly was done by a surgeon for a bigger chunk of tissue, which sometimes happens, but not usually. Okay. So I think this one is a little bit harder because it's kind of fibrosed. So this one, you're supposed to kind of think about Swiss cheese. So when you look at this, there are all these little circles of varying size. Right? These guys are all different. Some big ones, some small ones. And when you start seeing that, you start wondering about, a foreign material or injection. The prototype is, silicone. That people would get silicone granulomas back when they used to inject silicone for cosmetic purposes, which some people still do. And then I guess some of the breast implants, if that will rupture and leak, you can get the silicone granulomas around those. Also, sometimes people will inject foreign substances. There's paraphenoma. In men, sometimes when they would inject substances into the genital region. This is an example of a sclerosing lipogranuloma, which is in the latter context. So somebody injected foreign material for who knows what reason, and the body is reacting by, kind of get that sort of surrounding sclerotic change around the foreign material. This one is sclerosing lipogranuloma, which I don't know if he covered that in his. This one's kind of dirty. Looks like somebody broke it and then taped it back together. Okay. So this one I think is a little bit harder. When I was looking at this, I was like, what is going on? That looks like baby fat. Why is it so little? But, right, baby fat wouldn't be just in like random little lobules kind of dispersed, and this is not baby skin. So this one was labeled as, post-steroid, not post-steroid paniculitis like we talked about earlier, which is why people will take oral steroids and get that, which is in the differential diagnosis. This is like someone did intralesional kinolog, and the person got, localized lipoatrophy, basically. So in the kind of category of lipoatrophy, most of them are, you're talking about your generalized and, the familiar forms, non-familiar forms, but within the lipoatrophy, section of this chapter, there's a blurb about kind of localized lipoatrophy. So there's the one variant which can manifest like people, just idiopathic people get it like around their ankles especially, and they're not really sure on the etiology, but that form to me looks more like some variant of morphia. And then there's the, self-inflicted or physician-inflicted localized lipoatrophy related to kinolog. So you always warn patients about this, but this is basically that happened and it got biopsied. I think this probably rarely gets biopsied because most people know what it is. But you have, clearly you can see this is where, the fat used to be, so you've got loss of fat, and then in the remaining fat there's atrophy, right? These lipocytes look tiny. Which is why it's scanned. At first when I looked at this, I thought maybe it was baby fat. But, let's see. So these don't look healthy, right? They're miniaturized, and some of them are dying off. So, the last one. So, I'll go back to scan. So at scan, you do have some helpful clues. So, one is location. This slide is really dirty. Let me see. So you have an increased vascular proliferation within the dermis, right? And then if you go in and look at the vessels, so the vessels in the superficial dermis have kind of thickened membrane around them, right? They don't really look that healthy. So you have this increased vascular proliferation, kind of thickening of the vessel walls. So that's what you see in stasis change, right? So you got to use your context clues and they'll help you when they're there. So this is probably a biopsy of the lower leg. If you in sign out, usually you can always tell the location when you see those changes, because I mean even healthy people are going to have those changes on their lower leg. So we're probably dealing with something on the lower leg in the setting of stasis change, and then so a little bit larger caliber vessel there. Let me find a good example. So the fat does not look healthy, right? The fat doesn't look happy. So you have these kind of called microcysts. There's this microcystic change within the fat. So that's one helpful clue. And you have sort of a mixed infiltrate, and then you have these other areas that have kind of this change going on within the microcyst. Right, so there's some kind of histiocytic inflammation around this area of probably degenerating fat. I'm trying to find a really good example of lipomembranous change. So this is lipodermatosclerosis. So lipodermatosclerosis is, a change that you see a lot of times in people with long-standing stasis. So you're inevitably going to have stasis dermatitis in the background, and this is kind of the end extreme form of it. Okay, so here's a pretty good. So this kind of change, and if you let me go in high power. So kind of almost like feathery looking change. I know I used feathery before, I don't want to confuse you, but call that sort of lipomembranous change, and it's not specific for lipodermatosclerosis. You can see it in other things, but it's just a helpful clue, So you kind of just put it all together, and you obviously want history too, but stasis dermatitis, microcyst, mixed inflammation, involvement of the paniculus, lipomembranous change. Let's see if we can find. And sometimes you only get little focal areas of that, but more microcyst formation. Just general degenerative change. All right. So that is all of
Too, because it's just like